All right, so good afternoon, good evening, and even perhaps good early morning to our attendees here. Today we have a very interesting topic. We're going to be talking about keratoconus and how to personalize treatments in the management of keratoconus. And we have here, we're very lucky actually because at the Zaldivar Institute in Argentina, they've been doing this for decades, for many, many years, and they've developed a strong interest and expertise in using intracorneal rings in the management of keratoconus, along with other refractive procedures. And here we have Dr. Carlos Gordillo with us today. He's from Mendoza, originally from northern Argentina, and he's a cornea specialist who has a strong passion for keratoconus, ectasia, and diagnosis and management of this really interesting entity. And as many of our North American and perhaps more Canadian colleagues know, the way we do rings in Canada is somewhat different from the way rings are managed for keratoconic patients, whether it be in South America, in Europe, or the Middle East. So, Carlos, thank you so much for agreeing to chat with us. I know your colleague and my friend Juan Carlos was supposed to be here as well, but unfortunately had some issues that was not able to make it. I appreciate your input, Juan Carlos' input, and Adriana's input into your talk today. And without further delay, I'd love for you to share your thoughts and your experiences and your knowledge with us about using rings, and more specifically, how to personally customize treatments for keratoconus.
Thank you very much for the invitation. It's an honor for us. I'm representing Dr. Adriana Lotfi and Dr. Grandin, as you were telling, from the cornea department in Zaldivar Institute in Mendoza, Argentina. It's an honor to share this presentation with you and with all the Precision Cornea Center friends. So the idea of this presentation is to share some knowledge and to make like a whole information revival regarding the keratoconus from the beginning until now. So in the past, when I was like at med school, if I was looking for this information, usually what people were doing with doctors, were doing with the patients with keratoconus were contact lens until they cannot use it anymore. And after that, they were doing like corneal graft, PKP. That was like in the past, and this is something I tell the patients because it's not so many years ago. So it's very important for us to share that the treatment of keratoconus must be personalized. We cannot talk about general procedures to all the patients. We need to take care of each case as a unique case. We have a lot of classifications regarding keratoconus, and we have been like changing all the procedures and adjusting the information to different classifications. So until like 1 year ago and until this year, these classifications are still dynamic and are still changing, like the keratoconus. So I think it's really important for us, for all of us, to understand this. There are some classifications of taking care of the evolutive stage of keratoconus, the morphologic stages, the ABCD grading, or the Oviedo classification considering the topography. So this is for all the cases. It doesn't matter if it's in early stages or late stages. For all the patients with keratoconus, we need to stop eye rubbing. There is a very interesting presentation that Dr. Gattinero from France performed, showing with these images how the eye rubbing of the patient can affect the corneas. And apart from like halting the eye rubbing, we need to improve the corneal surface with the ponton plaques, with the eye drops, and anti-allergics treatment. So this is like for all the patients to start the presentations. So once we talk about this, we have some patients with a suspicious keratoconus in the topography with good visual acuity. What we'll do at the beginning is corneal surface treatment, and also we will have controls with the topography every 3 or 6 months, depending on the case. It's very important in these cases to ask if there is some keratoconus in the family, father, brother, sisters. Then if we have progression of keratoconus, we have to perform the corneal cross-linking. What happens if after the progression, we have also asymmetry of the cornea and affection of the visual acuity? We can use corneal cross-linking and intracorneal rings in combination. For these cases, we use the intracorneal rings in keratometric values under 57. And for those cases with affection of the visual acuity and keratometric values over 57, we propose the EDALC. So these are all the procedures that we are using, or alternatives we are using for keratoconus. As I was telling you before, the first option is the cross-linking. We are not afraid of performing cross-linking in patients with good visual acuity. The second chance is to use intracorneal ring and cross-linking in combination. After that, if the patient needs, after 1 year, we can also use phakic ICL or cataract surgery once the cornea is regular. If not, if the patient is in an advanced stage, we can use the corneal graft. And after the corneal graft, after 1 year, we usually perform also cross-linking in the peripheral ring to avoid the keratoconus reappearing in the peripheral corneal ring. This is very interesting also. So there are some papers regarding the different alternatives and treatment of keratoconus. And as you see, there are like a lot of options. If you have different stages, you can use only cross-linking, as I was telling you before, or combination of first intracorneal rings after cross-linking. We try to perform all together because we want the patient to be back to a normal life as soon as possible. Usually these are young patients and we need them to be back to normal life. For example, in this case, we perform only intracorneal rings because the patient didn't want to perform the cross-linking. So after a few years, you can see the progression. So it's very important to be clear with the patient and to understand that the progression of the keratoconus can be there. It doesn't matter the age. Before, like a few years ago, we were still listening. The keratoconus only progressed until the 30 years. It's not like that. We have evidence that the patients can't have progression after 30 years old. So after this, we can say that the intracorneal ring and the cross-linking are not competitive technologies. They are complementary. And the intracorneal ring is going to regularize the corneal surface, and the cross-linking is going to improve the biomechanical properties. We have published this report in Cornea magazine, Clinical Science, in 2016 with our database of keratoconus treatment with both procedures in simultaneous. And you can see the stability and also the safety of the procedure. We're talking about, when we talk about intracorneal rings, we have Intacs and Ferrari rings. We are using the Ferrari rings. The difference between them is that the Ferrari rings has a flat profile, and its compression of the internal edge of the cornea determines the effect. Originally, were designed by Paulo Ferrara, and then were marketed by different companies, Curve Ring, Corner Ring, and intraseg, it's the one we're using right now, because we have these thickness changes every 25 microns. It's very useful to customize the cases. So how to choose the intracorneal rings? So we need to be very careful with the inclusion criteria. We need to understand which parameters to consider. We need to understand how many rings, alternative of rings we have, how to do the surgery, and what to expect from the surgery. So in inclusion criteria, we need to understand that if we have patients with keratometric values over 57, it's probably that the intracorneal ring is not gonna work as we expect. So it's very important to understand this. The pachymetry is recommended to be over 400 microns, and the visual acuity should be the correct visual acuity of 20/40 or more. And of course, we need a clear cornea with no scars. This is a typical topography example. I put this picture because this was a patient that arrived to our consultation coming from another clinic with these intracorneal rings that were placed with femtosecond laser. So the deepness of the intracorneal ring position, it's perfect because it's almost 80% of the total corneal thickness. But as you can see, it's completely like ectatic cornea. So the intracorneal rings are not gonna be useful in this kind of cases. So for this case, we take out the rings and we perform a DLK. So what parameters to consider before the intracorneal rings? The visual acuity always, the manifest refraction, the autorefractometer values, the corneal topography, of course, and the patterns, the keratometric values, the aberrometric values or asphericity, and the corneal pachymetry. So the surgical plans are usually proposed considering all or some of these parameters, giving it more or less relevance depending on the case and depending on the surgeon and the experience. These are the different alternatives of intracorneal rings that we're having right now at the market. So we have the symmetric intracorneal rings, these shapes, and the only difference is that we have of 5 or 6 millimeters. We usually use the 6 millimeters because it prevents the glare of the patient. And when we're talking about asymmetrical intracorneal rings, we have designed this one with an asymmetrical base. You can see we have an asymmetrical base of 800 and 1,200 microns. And we also have an intern arc of 6 millimeters. And then there's another asymmetrical intracorneal ring of height. It's a progressive height with different technologies. So these rings were created to customize the cases. And once you select the pattern, you can be able to choose which is the best ring for your patient. We create the asymmetrical base intracorneal ring based on the theory that the rings has most effects as more thickness. And this is a timeline. It's very interesting because the first one to describe this was Dr. Barraquer at the beginning, saying that the intracorneal rings are an additive surgery. And after many years, until 2000, the history of the rings has been changing. And until the last few years, we start doing the intracorneal rings to customize the treatment. So another important thing to know is that we have a lot of nomograms. Actually, each surgeon can have his nomogram, but we have some guides. The important thing to understand is that the nomograms are guides. They're not the same for everyone. So we have created one nomogram that is really helpful to the surgeons at the beginning of the curve. So how we did and we developed the nomogram It was performed under an evaluation of our database. After 10 years of experience, we built this database and we performed a mathematical analysis with some experts from the university. And after that, we developed the nomogram. When the nomogram was developed, we create the software to make it easier. So this was the evidence was a retrospective study with this database of more than 1,000 cases. The inclusion criteria were, of course, the first 3 stages of keratoconus, and we were considering all the parameters that I was telling you before, and also the keratoconus phenotypes. I mean, with this, the corneal patterns. And of course, the time. What is the time variable? It's the comparative results on postoperative controls for each section. So these are some results. It doesn't matter right now. Then the important thing is to understand that this nomogram is going to help us because it's adjusted. The selection of each case was considered as more and better results were generated. It's dynamic also because every data entered to the nomogram generates a change in the results. And it's intelligent because the model replicates the decision-making of the training doctor. This is a video of how the application works. It's online and it's free. You can make a user and you have to upload the data of the patient, the age, the eye, and then you have to choose the pattern, and you need to upload your topography. Once the topography is uploaded, you'll have another step number 3. You'll have to put on the refraction of the patient, the axis. It's really important to put the correct axis of the manifest refraction, the keratometric values, the minimal and the maximal, and also the axis for each, and the visual acuity. You'll have the opportunity to add the undercorrected visual acuity, the corrected visual acuity, and also the pinhole information. So the last step, you'll have to upload the pachymetry map. You can use an OCT, or you can use also the topography map, and the minimal thickness of the cornea, and the pupil diameter. So once you have all the information uploaded, you'll make a calculation, and the nomogram will give you the response. And it's going to show you how many rings to choose, how many cases like yours we had solved, and the database results from our base. It's going to tell you the percentage or the average of improvement in visual acuity, cylinder, and keratometric values. So you'll be able to compare your patients with our database. And I think this is very important because you'll be able to see and to know how were our results, the good and the not that good ones. So here you have the link. If you want to try it, it's very interesting to start it. Nomogram.intersect.com. So let's start with the Sturgill technique. So as I was telling you before, we use the PMMA intracorneal ring, and the technique is also with a femtosecond laser and combined with accelerated corneal cross-linking of 5 minutes. So this is a surgical plan. How we do it? We have the corrected visual acuity, the refraction, the axis, and the incision, the thickness, and the selection. So for these cases, these patterns, it's identified as DAC. We identify as a paracentral and inferior keratoconus with a moderate sphere and cylinder, and corrected visual acuity that doesn't improve more than 20/30, with a good pachymetry and with a non-coincident topographic and refractive axis. So for these cases, we created this ring. This is the asymmetrical base I was telling you before. in 2017. So this is the video of the surgery. As you can see, we use the femtosecond for the tunnel creation and the incision. I can share with you all the parameters after for each ring. You can see the asymmetrical base ring. So once you have created the tunnel, you'll be able to introduce the intracorneal ring through the incision. And it's really easy to introduce the ring through the tunnel. And to center the ring in coincidence with the corneal ectasia. This was published in 2017, all the surgical technique and the parameters that you need to be aware. And it was also presented in Lima in 2017, then in ESCRS in Lisbon, and in ASCRS and the American Academy also. So what to expect from the intracorneal rings? We need to improve the corneal surface, to improve the visual acuity, reduce the astigmatism, and also to reduce the optic aberrations. What is important for us, it's very important to understand the corneal topography, to understand the topographical patterns, to understand also that the nomograms are a guide and that each case has to be customized. So here we have another case that is consultating because of bad quality of vision. It's a 29-year-old woman with this refraction, an undercorrected visual acuity of 20/80, a corrected visual acuity of 20/50, and this refraction. As you can see, there's a not coincident between this refractive axis and the topographic axis and the refraction. So for this case, it's a DAC with a non-coincident axis. We select the same ring as I was showing you before. And this is the post-operative image. At the 24 hours, you can see the different base of the ring. And this is a picture of the cornea. It's really clear. And the topography of the pre and the post-operative. Mostly you can see that the reduction of the astigmatism is more than 50%. But the good thing for this is that the visual acuity improves with correction and with not correction. So regarding the results, we have like very nice results with the corrected visual acuity and reduction of the cylinder that it's pretty important. So the manifest cylinder decreased from 4.83 to 1.17 in our frame database. You can also compare the visual acuity and the improvement between the symmetric and the asymmetrical base. But the most important thing here is to understand that if you use the correct ring for the correct pattern, you will have good results with both of them. And this is a picture of a patient, because Yukashif were asking me about the telemedicine. This consultation I was performing of a patient with a 3 months control of intracorneal rings. I did the teleconsultation with this patient, and we asked them for a picture. As you can see here, you can see perfectly the intracorneal ring. You can see the transparency of the cornea. You cannot see the deepness, but we're sure about the deepness because after the surgery, we did an OCT. So it's not a concern. So we check the visual acuity and the astigmatism during the telemedicine consultation. And this is how we ask the patient to show us, to send us the picture. And then in the computer, as you can see, you can make it bigger and you can see perfectly how the intracorneal ring position is. So as conclusion, we can say that the identification of the keratoconus type and classification is mandatory. The topographic image is required to identify the pattern for achieving the correct selection of intracorneal ring, as well as the number and position of intracorneal rings for each ectatic cornea. And also the implantation of the asymmetrical base intracorneal ring is an option allowing to customize the treatment of keratoconus, which is safe and reproducible. So thank you very much. This is some of our mountains in Mendoza. I don't know if you have any questions. I have some other information to share with you after regarding the tunnel creations for each intracorneal rings.
Okay, cool. Well, yeah, we definitely would love to see the information you have in a little bit, but perhaps we can ask a few questions and have a discussion.
Yes.
So I had a few questions coming along the way. So just going back to some of your earlier slides, at what point do you do or consider ICL after the initial cross-linking?
After the cross, usually we perform 3 controls at the month, 3rd month, 6th month, and for the year after the surgery, we can plan the ICL. Why is that? Because we have all the evidence of stability after the 6 months, but usually we tell the patients this information. So when they arrive to the consultation, they know that usually this is a very common question, because this is young people that are active with practicing sports or going to university. So they want to be back to real, to be useful again as soon as possible. But we don't do that before 1 year of the post of the surgery.
Okay, and do you find that with the ICLs afterwards, what are you telling them that their vision will be like? Are you telling them they'll still need some contacts? You still, because of the irregular corneas, what do you tell them in terms of vision afterwards?
Well, actually, after the first surgery, we use the contact lens, and once the ICL is performed, usually they don't need anything. It's enough. When you have a regular cornea, the calculation for the ICL it's good enough, and they don't need correction.
Okay, and then you also mentioned that you do the cataract surgery as well. Now, what do you use in terms of your calculations or formulae in these ectatic corneas when you're doing your lens considerations, and what kind of lenses are you typically using?
Well, for patients with previous surgeries in the cornea, we choose like a monofocal intraocular lens. We don't use multifocal for these cases. And the calculation is the same as always. We do the same calculation as a regular patient, because we have a stability in the cornea, so you don't need to be afraid of that. Okay.
So, for example, do you go out, some of our keratoconic patients, sometimes you use Pentacam with the machine we have at a wider zone. There's the cane formula now that people are using for some of the keratoconic patients. And any pearls in terms of calculations for monofocal lens?
Well, as I was telling you before, for keratoconus, we don't recommend multifocal lens. Right. We only use monofocal. And there's nothing special regarding the calculation after you have stability.
Okay.
So, because what we are looking for with this treatment with intracorneal rings is to regularize the corneal surface. So it's like I always tell the patient, we need to go back to the past. And we try to do it as much as, we try to leave your cornea as it was before the keratoconus start the progression. So that's the main objective, to have a regular cornea. Okay. And it's very important to talk with the patient, and it's very important that the patient understand the pathology, because you cannot compare a keratoconus patient with a regular myopia treatment with ICL or LASIK. It's very different.
Sure. Now, another interesting point you made was in your young keratoconic patients who are needing a corneal transplant, that once the corneal transplant is done, you do the peripheral cross-linking of the host cornea.
Yes.
Now, do you do that after, or do you sometimes do it before and then just do the full cross-linking so that, because the cornea will be replaced before surgery? So what are your thoughts about that?
That's a very good question. So I had a lot of experience with Dr. Malbram. He has patients of more than 50 years post-operative because he's 80.
Dr. Malbram, yeah.
He's 83. He described the dog, so he still see patients. And I did my residency with him, so I was able to see how the progression of the peripheral ring was appearing. So instead of doing a complete new cornea graft, he started doing this technique he called lamellar ring keratoplasty. But it's a lot. So we instead of doing a new surgery in the future, we perform the cross-linking in the corneal ring. So for young patients with advanced keratoconus in both eyes, we'll do first a cornea graft in one eye and a cross-linking in the other eye until the graft is performed.
Okay.
That's an option. Then another option is the patient cannot go to the surgery because of, I don't know, he has to study or he don't have the opportunity to perform the surgery right now.
Right.
You can do also the cross-linking, so you avoid the progression and the eye drops. But in those cases where you have not performed the cross-linking in the peripheral ring before the surgery, you have to do it after. Usually we tell the patient that after 1 year of the cornea graft, we're going to perform the peripheral cornea cross-linking, and it's really interesting, the technique. Actually, we have shared this technique with Dr. Price, and we're working on the publication together. We protect the center of the cornea, and we perform the cross-linking in all the peripheral ring. And it's very nice because the interesting thing to know about this is that we're going to have always good pachymetry maps in the peripheral cornea. So you don't need to wait until it's thin. You need to check only the epithelial changes, and it's good enough to know that the progression is there.
Okay, so I think that's a very interesting point, and for those patients, for those people in the audience, it really is this progression that occurs in a young keratoconic's life after they get a transplant, that the peripheral cornea still may progress. So the idea here to do the cross-linking to wait during the time they have to wait, as Dr. Gordillo mentioned, or after the transplant is very important to minimize the changes that can occur decades later after the transplant is done.
For those cases that we have some cases that don't come back to the consultation and they appear after 6 or 7 years with progression and with new astigmatism that was not there before. So you can also use the rings and the combined techniques, and you can introduce the intracorneal rings of 5 millimeters in the cornea graft and perform the corneal cross-linking in the peripheral ring.
Okay. So can you tell us a little bit more, when you work with the rings, how you look at the topographic axis, how you look at the refractive axis? Because in the audience here, we have some techs and some optometrists who work these patients up. So when they're doing the manifest refraction in these patients, any tricks you have in terms of determining the axis of refraction?
Yes, well, that's very important. Nowadays we have a barometry and we can, we know, you know, like with the technology, you have, like with the Pentacam, all the information you need. But our database, the one we build all the nomogram, has no this data. So these nomograms is gonna help you with only with the manifest refraction and the axis and the topographical axis. It's not gonna have the aberrometry included there. So for the beginning, it's gonna be good enough. The problem is when you have a difference between the manifest refraction and the topographical axis. There, in those cases, probably you will have high aberrometries, and you will have to use an asymmetrical base, intracorneal ring, or an asymmetrical high. But that's a really complicated topic to explain, but we can do like a special class regarding the axis and the refraction for the calculation. This was like a little bit general class of keratoconus.
Yeah, no, I agree. Like, and this is something we impress upon our team when doing other refractions, how critically important it is to get the measurements right, especially with the axes. And the other question I had was with respect to, you had mentioned that you want to have a keratometry of less than 57 at diopters for the rings, and you also want corneal thickness in that area of 400 microns. And so can you tell us, in a patient who's got, say, 400 microns or 500 microns, what is the depth at which you place the rings, and is it different for the asymmetric ring versus a regular ring?
So the depth is always, we are always trying to do it 80% of the total corneal thickness. Consider that we are performing usually both techniques, cross-linking and intracorneal rings. And you, for safety, you need a 400 microns corneal. Yes. Because otherwise you can damage the endothelium and it's not going to be useful. So that's why we choose this pachymetry criteria. And as I was telling you before, we choose the 57 keratometric values as maximum, because otherwise the ring is not going to give you the effect that you're waiting for.
Okay. Okay. And does the intraseg nomogram website go into the size of the segment, plus also how centrally it should be placed?
Yeah, of course.
Okay. Okay.
Yeah, it gives you all the information. And then there's something interesting that, for example, if your patient has an axis that is not coincident with the topographic and with the manifest refraction, it's not going to be automatic. It's going to send you to a human response. And the three of us are doing this. So if there is some special case that the nomogram cannot understand or give you like the robotical information, it's going to be sent for us. So we have like 48 hours to give you the manual response. Usually this is happening with those patients that have these special cones, as I was showing you before, for the asymmetrical base. And then the other question you were asking me, if the parameters are different for the asymmetrical base, in the deepness is the same. It's not a problem of deepness. It's because for thickness cornea, it's much better because you have the asymmetrical thickness ring. Okay. It's not with a high.
Okay. And so now you've painted a nice picture in terms of what the extreme or what the upper limit you would be for K readings and corneal thickness to put a ring in. What about the other side? What is the lower limit? At what point and what considerations do you have to start thinking this is a good time to put a ring in?
Well, like usually the patients that arrive to our consultation the beginning, the first stages of keratoconus, they don't feel comfortable with the lights during the night, and they tell you that. So they have correction, they have glass or contact lens, and they don't feel comfortable with the lights. So the aberrometry is going to tell you, because you can have a 20/20 visual acuity, but the quality is not good. So that's good enough to start with the patient. Once you have an asymmetrical topography, it's enough to choose an intracorneal ring. You also can use at the beginning a 150 ring, it's the small one.
Okay. And so along the lines of the aberrometry analysis that you do, so, you know, we've been classically taught to look at things like vertical coma when diagnosing keratoconus. What parameters are you looking at? I remember you seeing on the slide, you mentioned spherical aberration, but what parameters are you looking at on your aberrometer to guide your decision-making?
Well, actually, the only thing you need to know is that all the keratoconus patients are going to have high aberrometries. It's only that. After that, actually, as I was telling you before, all this database where the aberrometry maps were not using because we didn't have the machines. Mm-hmm. So it's something that it's new for us also. We're using it now, but we're only checking the axis of the aberrometry and comparing the refracted and the topographical. But all the patients with keratoconus are going to have high aberrometry maps.
Okay, so now if you have patients where you respect the rules that you've mentioned about the, you know, maximum K readings and the minimum thickness, what can surgeons who want to start doing this more frequently, what should they be aware of in terms of potential complications, in terms of potential scenarios where they are scratching their head thinking, what should I do next? What are some of the things, some pearls that you would say, be aware of these issues?
Well, actually it's pretty safe because it's a surface surgery. So the main problem of this is to understand how many rings to put and where. So the main problem would be that the topography after you put the rings is not good enough for the patient, and you can take it out. It's not a problem because it's really easy to change and to redo the surgery. So of course, if you do it once, it's much better. Right. But this is the main problem. And the other thing is that if you don't put the ring in the according deepness, you can have an extrusion. That's another problem.
So can you tell us more about extrusions? Are there certain types of patients that it happens more in? Like, for example, eye rubbers, do you find it's really a question of how deep the implantation was that leads to the extrusion, or are there other factors at play?
Yeah, mostly has to do with the corneal pachymetry. Because if you don't have a good pachymetry, you are not going to be able to go that deep. But with a good corneal pachymetry and the corneal deepness, you're not going to have this problem. But if you have a patient that is still rubbing the eye, you have the possibility to do that. We also had a case of a patient that was sleeping on this side of the eye and was doing this during the night. That's another problem. So for those patients, we recommend to cover the eyes during the night until they get used to stop with the eye rubbing. Okay. But it's not very frequent. Like I think I've seen 2 or 3 cases only in the last 5 years.
Of extrusions?
Yeah.
Okay. You know, we have had a few along the way. And so one of the questions I had for you is, once you have seen an extrusion and you take out the ring segment, what do you do afterwards for helping the patient see better? What are the options? So
usually we wait for 3 months until the corneal surface is safe and and after 3 months, we can do another intracorneal ring surgery. But we wait because sometimes you have a memory on the tunnel, and sometimes that scar helps the patient with the regularity of the cornea.
Okay. Okay.
But
Okay.
usually we wait 3 months.
Oh, so you wait a certain amount of time and then consider then reimplantation of another ring segment.
Yeah.
Okay. And then how about what are your what laser platform do you use? Your topography guided laser platform, and how, at what point does the debulking of cylinder happen with the laser?
So we at the institute we have the intralace.
Okay.
And the other question was,
sorry, do you use a topography guided excimer laser in your management of your ectasia patients?
No, for these cases.
Okay.
Dr. Zaldivar used it for the LASIK procedures.
Okay. Okay.
But the Technolas, but we don't.
Okay.
We don't need it for the intracorneal rings.
Okay. Now, did you have some other slides you wanted to show us in terms of settings and things like that?
Well, actually, yes. I'm going to show you. This is from a book that we have regarding how to perform the surgeries of intracorneal ring, and it's pretty useful. It's also the nomogram. If you use the nomogram application, you can see this. For once, it's in Spanish. I'm sorry for that. Once you choose the intracorneal ring, if you have a 5 millimeters or 6 millimeters ring, you'll have to choose the internal diameter and the external diameter. For those rings less than 200 microns, you have these parameters also for the symmetrical and the asymmetrical base. With these parameters, you're going to be comfortable to introduce the intracorneal ring through the incision. And for major diameters of ring that you select, you'll have to change mostly the external tunnel diameter of the settings.
Okay. So, and typically, how many ring segments do you implant every, I don't know, month or every year? What kind of volume are you guys looking at? Because obviously, to get up with your database, to do the nomogram must be many cases.
Yeah, it's pretty big. It's been changing a lot. You know that in Argentina, it's the economy is also a lot to do because we have been like having huge problems. So the rings price is changing, and sometimes the patient has to wait until they have stability. But usually, like 2 years ago, we were performing between 12 or 20 intracorneal rings by week.
Wow, that's amazing.
That's big. And also Juan and Adriana performed the intracorneal ring surgeries in Buenos Aires. In Buenos Aires we have the main population of the country.
Yes.
And then in Mendoza there are people coming from different provinces, so that's why we have a huge volume. Okay. It's not just our state. So there are people coming from different countries or states next to us. Right now we're not performing at all because of the situation.
Oh, okay, I see. Now, for surgeons who are looking at starting, or centers that are looking at starting, what would be an ideal case to start with?
Well, the ideal case is that one I was showing you before, an asymmetrical paracentral inferior keratoconus. So it's because only you will use one ring.
Right.
Ectatic area, and it's pretty safe, and the patient goes really happy because you'll have a immediate change in the topography and in the refraction.
Okay.
You need to be careful. That's another interesting thing, because the first month the patient will be really happy because if they have myopia, they're gonna have like less myopia the first month because the ring is gonna give the cornea more tension.
Right.
So they're pretty happy the first month, and then after 1 month, it becomes the myopia can come back. So
Sure.
you need to tell this to the patient.
Okay.
And you give the final refraction, the contact lens or the glasses, when the patient has 3 months after the surgery. In between, you can use the antique refraction or disposable contact lens.
Okay. And then at the time of the ring implantation, what method do you use for cross-linking?
We use accelerated corneal cross-linking of 5 minutes, 18 millivolts in 5 minutes. Epi off, always.
Epi off, yes, yes. Okay, and then again, to some of the our residents or techs or optometrists that may see these patients post-operatively. So on the post-op 1 day and the 1 week and the early post-operative period, what would be looking for?
Well, immediately 24 hours after, you need to look for the incision, if it's closed or open, and of course, if there's no infections. You need to look for the position and the deepness of the intracorneal ring. That's it. So
with the OCT, you do that?
Yes. Yeah. Well, you can do the OCT if you have it. If you don't, you can see the deepness in the slit lamp.
Okay.
Usually, we always do the OCT 24 hours after.
Okay. Okay. And at the time of the ring implantation, when you're using your riboflavin, do you inject it into the tunnel you've created, or do you just simply do it as drops?
No, we only do drops. After we perform the tunnel and we introduce the intracorneal ring, we take the epithelium off. We make a big ulcer, and then 20 minutes of eye drops. You can choose with dextran or without dextran, depending on the corneal deepness.
Okay.
And after the 20 minutes, you perform the light irradiation of 5 minutes.
Okay, awesome. You know, with COVID going on, we're not traveling as much, but I want to travel down to Mendoza and see you guys in action. This is really great. It's very, it shows how much experience you have. So I do appreciate the time that you have spent and the time that Adriana and Juan Carlos have spent as well in terms of helping us understand this a little better. Any questions from the attendees? Yeah, this is really useful. So one question I have, just a very, for me, very basic question is, these rings, intraseg rings, Carrera rings, are not available for us in Canada. So have there been people in Canada using it through special access, or any thoughts on us gaining access to these, to this technology?
Well, actually, they have the same problem in the US because they don't have the permission with the FDA.
Yeah.
So I really don't understand why, because the reports and the history has shown us the safety and how useful it is for the patients. Yeah. If you look to Europe, they have been using this for many years. So I really don't understand why the industry is not allowed in your country yet. That's
so, you know, perhaps we can talk offline that, because if a product has CE mark, sometimes we can get access to it. So I think it's worth exploring this further, because I do find, as we've started this new clinic at Precision Cornea, that we overall have been underdiagnosing, not so much, but maybe undertreating our keratoconus patients, whether it be from a stability point of view or whether it be from a refractive point of view. And so I think we are learning from experienced people like yourself. And so now we have to kind of, you know, do a little better. And so
for intraseg, you have the CE. You have for intraseg for sure, you have the CE approval, so you can use it. And please feel free to contact us for any doubt or for these patients, because if you're not treating them now, you're gonna have to treat it in a few years. So I think it's pretty important if you have a corneal center to identify the cases. And it's, if you have femtosecond laser, it's so easy to begin, and it's really easy to understand the way to put the rings. So yeah, I think it's pretty good option. Also, because if you let the patients, let's say that you have a keratoconus that is not changing that much, this patient is going to have a high aberrometry map, and in the future is going to have a cataract, and you'll have to make a surgery with not regular corneal surface. So the problem is going to come sooner or later.
Right. Okay. Well, Carlos, thank you so much. That's been very, very informative. We will, as I mentioned to you, this has been recorded, and I'll let you know when it's going to be on our YouTube channel. Many of our group and trainees look at these videos afterwards. So thank you so much for your time to have spent with us. Please pass on our thanks to Adriana and to Juan Carlos as well. And I definitely hope to see you in person and to get more and learn more from your experiences.
Thank you very much.
Okay, have a great evening. Thank you so much again.
Time for you. Good night.
Okay, bye-bye.
Bye-bye.